everybody to this special program tonight, oncology. Ever since his residency, he's had a special interest in skin cancers and melanoma. Dr. Sirott.
Thank you. It's actually since fellowship I did my research with melanoma, a long time ago. So before I talk about the medical perspectives, I wanted to add a little bit about radiation treatment. We don't use radiation as much in the treatment of skin cancers. It has a small role for certain patients. In patients who the loco-regional, remember that word from his talk, where that control is not felt to be adequate by surgery, we will often use radiation in that area. So it can be, usually it's aimed right at the lymph nodes. So if he goes in there and there's 4 lymph nodes involved, or 5 lymph nodes involved, or the lymph nodes are bulky, they're big, and they've broken through that nodal capsule, we'll radiate that area to prevent the cancer from coming back there. Sometimes we use radiation for more advanced disease as well. We also use it in some of the other skin cancers. We mostly talked here about squamous cell, basal cell, and melanoma. There are a variety of other cancers that affect the skin. One that is on the rise is Merkel cell tumor, which almost nobody has ever heard of. It is used to be thought of as an extremely rare tumor. It's not anymore. And the reason it's not rare anymore is partially because it's on the rise, but also because of sun exposure, but also because pathologists are diagnosing it more. We can now do special stains and realize that a lot of what we used to, not a lot, some of what we used to call other tumor types were actually Merkel cell tumors. And Merkel cell is another highly lethal cancer. It is much more similar to melanoma than any other tumor. We do radiate the primary site and the nodal site for Merkel cell. We use radiation for lymphoma. Lymphoma is a cancer of the white cells, and sometimes it occurs on the skin because there's white cells in the skin. Once in a while, there's other types of tumors like Kaposi sarcoma. That's an AIDS-related disease, usually, or a sarcoma, a cancer of the skin of older patients, particularly Jewish patients, and we use radiation for that treatment as well. We don't use external beam radiation therapy treatments very much for squamous and basal cells. They mostly get cut out. Most of that is handled by the surgeon. There are rare cases where the tumor is large, or the surgeon gets out most of it but can't get out some of it because of another structure nearby. Once in a while we'll use radiation. For the most part, these cancers are treated with surgery, and hopefully that's it. If I'm getting involved with the patient, then it's a more significant cancer. So let's talk a little bit more about melanoma. What Dr. Young didn't say is why he cares about the lymph nodes. He said for local regional control. That's what he takes care of. The problem with nodal involvement is what I take care of. When there are lymph nodes involved, the concern is that the cancer either has or will spread, that it will show up distant from wherever it started. And when there are nodes positive, the risk of that is very high. I should say very high. It's much higher than if they're not involved. And if that tumor is thick, remember he talked about the various thickness stages? By the way, that's called Breslow thickness, after Dr. Breslow figured out that that's what's important. If the tumor is thick, and very thick is 4 millimeters, if it's 4 millimeters, I see the patient and I treat the patient. If it's an intermediate thickness, he sees the patient and he'll take the nodes out. If the nodes are negative, and in general, and the tumor stage is 1 to 3 millimeters, I won't treat the patient. They don't need it. The risk is low. There are exceptions to all these rules, as Dr. Young pointed out. What do? I use adjuvant therapy. Adjuvant therapy is treatment when we think we've surgically cured the patient, but the patient is at risk for relapse. For whatever reason, we use adjuvant therapy in almost all cancers now. The adjuvant therapy that we use in melanoma is interferon. It's been around for a long time. The way it's usually given is cumbersome because it's a long treatment course of about a year, and it's a fairly difficult treatment course. What does it do? It reduces the chance that that cancer is going to show up again somewhere else later. By the way, before we do any adjuvant therapy, we always check to make sure that the cancer hasn't already spread. What about chemotherapy? Chemotherapy, I don't like the word useless because I use a lot of chemotherapy, but in melanoma, it's close to useless. It's been used in melanoma for 40 years. There is one drug that is actually FDA approved for melanoma. It's an old drug. It has a modest activity. It can shrink a few cancers. It doesn't do much more than that. And I don't think I've used that particular drug in probably the last decade or more. We only use chemotherapy in advanced disease. And we only use chemotherapy when other stuff that we now have isn't working. Within the last 10 years or so, there was a combination of biologic treatment and chemotherapy. Some people still use that. I actually think the biologic therapy is what's working. So in general, chemotherapy is relatively ineffective for melanoma. Biologic therapy is where the action is with melanoma. There's been a couple new drugs released recently. The first biologic therapy that is successful, other than the interferon, which is also biologic, is called Interleukin-2. Interleukin means between white cells. And basically it's just a chemical way that cells talk to each other. And Interleukin-2 is simply an immune stimulant. It's a very specific one. It was actually developed while I was a resident in the 80s, and that's where I first started using and being interested in interleukin. And when it started, there were a couple things about it. A, everybody thinks of immune stimulating, oh, nice, easy treatment. Interleukin-2 is a very difficult treatment. It's administered usually in the intensive care unit. It's 5 days of difficult treatment followed by 7 days of even harder recovery. We do that a couple times, usually 4 now if it's working. It's complicated. Most places can't do it. And in fact, for a while, up until fairly recently, John Muir was the only hospital doing it in the whole Bay Area. And that was because me and a couple of my partners have used it at other academic centers. UCSF, their melanoma center was run by a dermatologist, an excellent physician, by the way. But he doesn't do this kind of stuff. And they didn't have anyone doing it up until a couple years ago. Dr. Dowd is there now. And they also do IL-2. It's only for a few people. Most people can't tolerate the rigorousness of it. And in my opinion, it should be in the patients who it has the most likelihood of helping. So it's a tough treatment. We don't use it that much. But it is the first therapy that ever cured metastatic melanoma. The cure rate is very small, much more modest than we'd all like it to be. But before that, there were no cures, unless Dr. Young can cure them with surgery. Once in a while, if there's just one site of spread with melanoma, you can surgically resect it, and you'll get a rare cure that way. 2011 was a big year for melanoma. We started hearing about ipilimumab. Anything that ends in MAB in medicine, it's a monoclonal antibody. It's a biologic agent. Yervoy came out in 2011. When we started hearing about it, it sounded like no one would believe it because the responses they were seeing were quite impressive. Turns out it really is true. It's an interesting drug. It doesn't really stimulate the immune system. It turns off the off switch and lets the immune system be stimulated the way it's supposed to be. It has a survival advantage. It is the first treatment in melanoma that has a survival advantage across all patients. Usually with the interleukin-2, we were seeing a few cures, but the overall response rate was so low that we didn't move the median. This drug moves the median. We're still waiting to see if there are cures with Yervoy. There is a physician in our community who was one of the first people I ever heard of to get this drug 4.5 years ago. He has melanoma. It is metastatic. He had failed interleukin-2. And I forget where he went. He went fairly far away to get it because it was so new. I hadn't heard of it. He's still in remission, complete remission. And that impressed me because we don't hear that very much. So we know it's a real drug. We're still trying to figure out how to use it. It is also fairly toxic. Not like interleukin-2, it's an outpatient treatment. One of its downsides is it's one of the most expensive drugs we've ever used. Another drug came out at the same time. It was like 6 weeks later. It was we just don't see that very often. Called Vemfuramib. It's an NIB, NIB, yes. Whenever you see a nib on the end, that means it's a small molecule protein, and it's usually a tyrosine kinase inhibitor. Zelboraf inhibits a gene called BRAF. What's interesting about it is you can check if the patient has the mutation. The mutation is a V600E mutation. About half the patients have that mutation. If you don't have the mutation, no reason to go on Zelboraf. It absolutely will not work. It works. It does work on the patients with the mutation. It works by killing the cells. Actually, it lets the cells die the natural death that cells are supposed to die. All of our cells in our body are supposed to die at some point, and they're replaced. Maybe except for brain, which is dying in all of us slowly. This tumor induces apoptosis, which means programmed cell death, and those patients, again, live longer than patients who don't get Zelboraf. Both of these drugs are released, and now the current trend is to figure out how to combine them with Interleukin, if that's a reasonable thing to do, perhaps with interferon. We've done a whole lot of trials of combining Interleukin with interferon, and they were no better than Interleukin alone. And in fact, interferon is very, very rarely used in advanced disease. It has a 3% response rate. It's pretty low. So these are some of the new breakthroughs in the biologic agents for melanoma. When we start talking about long-term responders or cures, we get excited in a disease that before was quite resistant. Just a few words about the California Skin and Melanoma Center. We set this up because there is no dedicated skin cancer program in the East Bay. There are dedicated skin cancer programs in other areas. There's 2 in San Francisco, but there's nothing on this side of the bay. And we have some physicians who are interested. So what are our goals? This is one of them. We want to raise community awareness about prevention, which is, of course, the best way to deal with cancer is to prevent it. We want to promote skin cancer prevention. We want to set up educational programs like this for kids, particularly the young girls who are tanning and going to those tanning booths even though they're not supposed to. We're working to get some active clinical research, some of those new drugs. We'd like to investigate them here in melanoma. Our goal is to work with a dermatologist and work with the patient's primary care physician so we're all on the same page. So there's what we said, no other program outside of San Francisco. The most important thing for a program like this is physicians who are interested in the disease. And that's one of the key features of a dedicated center. So there's a breast program in the area. The surgeons who operate on those patients do lots of breast cancer. The medical oncologists who go to the program, they see almost all breast cancer and not a lot of other cancers. So the radiation therapists who deal in that breast center, they specialized in the features of radiation that are used in breast cancer, etc. So we want that here for skin cancer. So we have a dedicated pathologist. Pathology is very important in skin cancer. It's hard sometimes to call. It sounds easy. Sometimes you can't tell if that melanoma is invasive, or is it really squamous cell, or could it be a Merkel cell? And by the way, that is a huge difference in treatment. So these questions are important. So we're raising awareness both within the physician community as well as in the patient community. The goal of our center is to set up comprehensive individualized treatment plans. We do that partially through a multidisciplinary tumor board. A tumor board, which started in breast cancer but now is spreading to other cancers, is where a patient is presented and all the physicians involved in the care or involved in the care of that disease look at that patient, and there's a surgeon there who says, here's what I think for surgery. There's a medical oncologist saying, well, here's the options. There's a radiation doctor there. We actually see the pathology on a projector, and the pathologist, we actually get a second opinion on the pathology that way. There's usually a radiologist there to look at x-rays that might be indicated. In melanoma, there's certain advanced diagnostic imaging techniques that you need to be able to do to be doing it well. Sentinel lymph node evaluation is one of them. Advanced scans for metastatic disease is another one, which is common here, but in other areas of the world, or even the country, you can't get these sorts of scans. And then we want to be able to offer our patients state-of-the-art therapy. So that's why the California Skin and Melanoma Center exists. We just started up. This is one of our first talks. We plan on doing more of this. I think that's the end for me. Thank you.